Well, good morning, everybody. So, I'm Raphael DAUTRY. I'm a French resident in Paris. First, I would like to thank Dr. Laurence Belaïch, who kindly provided this case. Almost there. Okay. Something went wrong. Okay, so this is the patient is a 31-year-old woman who presented with right hip pain for the last 5 months. She has a phlegm when walking, and she has an unremarkable medical, surgical, or traumatic history. On clinical examinations, she presented with diffuse mild pain on passive and active mobilization and normal radiographs. So, which imaging would you recommend?
MR.
Okay, so she had MR. Good.
Some specific MR.
Actually, phlegm was reducible, so everything went fine. So we performed the coronal and T1 weighted and T2 weighted acquisition that display bone marrow edema, mild effusion of the hip joint, and edema of the soft tissue. So, do you need another sequence?
Sure. Let's see a start.
So actually what we did was a gadolinium injection in order to study the enhancement pattern and to see whether or not the synovium was enhanced, which, so the enhancement pattern was not specific with diffuse enhancement of the edema and mild synovial enhancement. So what are your main hypotheses in front of this imaging? So this is what we have evocated. First, an infectious etiology, then a stress fracture, intra-articular osteoid osteoma, avascular necrosis, transient osteoporosis, or other inflammatory terms. So we shall briefly discuss this hypothesis. First, the infectious etiology. Bone marrow edema and the effusion and mild synovitis could be consistent with this, but there was no infectious context, which is quite enough to rule out this hypothesis, and there was no images consistent with the Brody abscess. Now, the hypothesis of an intra-articular osteoid osteoma proves the location at the femoral neck is classical. Bone marrow edema and non-specific effusion and synovitis are also consistent with this. Against this hypothesis, no nidus visible, but now if the nidus is small, it is often not visible on MRI. Stress fracture. The location at the femoral neck is also classical. Bone marrow edema and effusion is consistent with this, but radiographs were normal after 5 months of evolution. There was no clear cortical thickening, and there was no activity classically leading to stress fracture. Transient osteoporosis, so bone marrow edema, but the pattern is not really consistent with this hypothesis. And effusion is a common finding, but non-specific. And there was no clear osteopenia in the radiographs. Early stage AVN, bone marrow edema is a classical manifestation, but in this case it was centered on the femoral neck, and joint effusion and synovitis are usually not seen at early stages. So, which other examination would you recommend?
CT.
Yes, we do need a CT, and here it is.
That's the one.
So
No twins.
the image is quite typical with the radiolucent nidus, in this case very small, 4 mm, with a 1.5 mm dense center, which quite explains why it could not be seen on MRI, and no or moderate cortical thickening in this case. So, a very brief shortly about intra-articular osteoid osteoma. They represent 10% of all benign skeletal lesions. They affect most frequently young male, and intra-articular osteoid osteomas represent approximately 10% of all osteoid osteomas. In this case of intra-articular, hip is the most common side. So what are the key differences with classical intra-cortical osteoid osteomas? Well, pain is not necessarily worse at night. Joint effusion may be the prominent symptom, and it can be accompanied, as it was in this case, by inflammatory synovial hypertrophy. And the reactive cortical thickening is minimal or absent, as it was in this case. So in conclusion, intra-articular osteoid osteomas must be considered in the differential diagnosis of any monoarticular osteoarthropathy, especially in the hip. MRI appearance includes medullary and soft tissue edema together with joint effusion, and CT remains, of course, the technique of choice to identify the needles. Thank you.